After looking at all these consultation models, you're probably starting to realize that there's similarities between all of them. Let's take a look at them in further detail. You've probably started to notice that as we move through time to more recent dates, the consultation models start to get a little bit more complex, with the exception of the consultation hill, which I think simplifies the process quite well. In this video, we're going to take a look at how we can understand the orientation of the consultation models and what similarities they all possess. When you've looked at these models, you've probably noticed that they get more complex as time moves on to more recent times. And you've probably also noticed that there are actually some similarities. Some of the common similarities between them are that all models include the taking of a history, examination, and coming to a differential diagnosis and eventually diagnosis. There are some differences in the way that that's relayed to the patient, and I think you'll probably agree that as we've moved to more recent times, the models have placed more of an emphasis on sharing the consultation with the patient and involving them in the decision making. But really, what we can do is say that the models differ in three ways. The first is that we can say that the conceptual framework differs, and what that means is that what's to be achieved and how to get there is different across all of the models, although some of them follow the medical note model of acquiring a history, doing an examination, and arriving at a diagnosis. We could also say that the centeredness is different, and the orientation between the practitioner and patient is different as to whose goals and whose agenda are addressed. We can say as well that the tasks are different in that it's sometimes orientated to task completion in acquiring a diagnosis and getting the patient on the way, but sometimes it's got more of a behavior orientation in that we're trying to modify behaviors in terms of social habits, health habits, and trying to promote health, for example in the Stott and Davis. And a useful way to think about this is to actually plot it on a chart. And what we can have is some consultation models are more aligned to the doctor or practitioner. And we can see this in things like the model naught or perhaps the neighbour, where these are more aligned to the doctor's needs and not addressing the patient. Conversely, we can have them aligned more to the patient. And we can see this in the addition of the Calgary-Cambridge models and models later on, where they're more addressing the patient's ideas, expectations, and concerns. For example, in the ICE model. We can also plot them in terms of how orientated they are to the task. If we look at some of the models, for example, the medical naught model, these are very orientated to a task, completing a task and sending the patient on the way with a diagnosis and job done. But we can see in some of them, for example, the Stott and Davis or the Calgary and Cambridge models, that they're sometimes aligned to behavioural changes in the patient, health promotion, and that goal that we all have of that ideal consultation. So how does all of this work? And what we've already established is that these models are ways for us to depict what might happen in real life through a hypothetical flowchart. And it's quite obvious that we don't always stick to completing the 71 points of Calgary-Cambridge or do everything in necessarily the same order. And what you will find, and a good point for your assignment, is to have a think about what your consultation model is. And you may have already realised that as you work through these 7 models, that you can pick out bits from each of them. And what we actually do in clinical practice is we're making our own mental model, how to see a patient, how we do things, and this will be an amalgamation of everything. But what these models do is allow us to see how a consultation could play out in real life, apply that to the real world, and then refine this as well. And what you'll find, I think, if you reflect, is that you've probably got your own version of a consultation model in your head. And that's why I said at the start of this presentation that we all make our own models.